When Americans started drinking more during the pandemic as a way to cope, what we didn't understand at the time was just how widespread and critical this issue was to become. But a recent study that was released by the Journal of the American Medical Association reported that between the years 2019 and 2020, alcohol-related deaths increased by 25%. And so how we treat alcohol use disorder is a vital piece in addressing this current crisis and an important discussion to have. I was fortunate last week to sit down with Dr. Paul Linde, and here's what he had to say about it. Dr. Linde, I'd like to start off by asking you, are you surprised by the statistics that came out in the JAMA report, or was this something that you saw coming?
I would say that they're surprising, that I think we've been really aware of the increase in drinking, particularly during the COVID pandemic, but I don't think any of us would have anticipated the degree to which it would be causing such an increase in mortality.
And what are some of the main reasons that people become addicted to alcohol?
So there's a very complex interplay between nature and nurture. I think it's pretty clear that with the increase in drinking with COVID, that the majority of the increase in that behavior is from stress and social isolation. You know, one can imagine how things change for so many people, particularly people with children, people now working from home while trying to do other things at home, and then being socially isolated. And that combination of really severe psychosocial stress, along with perhaps a genetic susceptibility, has led to increased drinking during COVID. In general, addiction specialists think that the role of genetics in developing a substance use disorder of any kind is probably about half, about 50%. When we look at the other 50% slice, it really includes a combination of two different things. It includes those who have had a history of significant trauma, and having significant trauma in your life is a precursor to developing a substance use disorder. This could come in multiple different ways. It could be chronic trauma from either abuse in the home or neglect. It can also be from single episodes of trauma, being a victim of violence or sexual assault. The other aspect, though, of that 50% slice of nurture is what is observed in the home, what's learned in the home. What are the behaviors that are being modeled around alcohol use at home? And those things are learned. What are the behaviors in your peer group? Are you in a peer group as a teenager of people who are drinking a lot of alcohol or using other drugs? And so those other social factors play a role as well.
Absolutely. And so once you realize that you have an issue with alcohol that needs to be addressed and you're ready to get treatment, what are some of the biggest challenges for those people who are ready to get help?
Well, I think clearly the number one issue is stigma and shame, that people who have a problem with alcohol or other substances have a lot of shame around it. And in fact, I think because alcohol is so available and so accessible and really even celebrated in our culture, if you think about the role of alcohol, that it's really gone beyond being acceptable to being something that's idealized. And so to overcome that, I think, is really difficult. In addition, access to services to stop drinking are somewhat limited. The tried and true approach has been to go to 12-step meetings, Alcoholics Anonymous, for example, and to commit immediately to abstinence. And for those people who are ready for abstinence and are ready to take that on, AA is a great resource and has saved countless lives. There's another subgroup of people, though, who, however, who are not really ready to commit to abstinence. And sometimes for those folks, it takes a different approach for them to get better. If you think about adolescents and young adults in particular, and we have patients at Ria Health who are in that age, I can only imagine how difficult it is to go to an abstinence-based model when there's really a greater emphasis on drinking, you know, among adolescents and young adults than perhaps older groups.
What would you say is the role played by physical dependence on alcohol, and how does this compare to other substances?
That's a great question. And I think it helps maybe just to review quickly what is a substance use disorder Essentially, any substance use disorder currently is defined by DSM-5, which was developed in 2015 by the American Psychiatric Association. And essentially, it really streamlined our criteria for substance use disorders, and I think made it much more understandable of what would constitute it. And it's complex. And honestly, there's both a physical aspect to any substance dependence, and there's also behavioral aspect as well. So we'll focus on the physical for a second. Alcohol and sedative hypnotic drugs are really the only drugs that you can die from withdrawing from. That alcohol withdrawal or withdrawal from sleeping pills or other sedatives can be fatal. Opioid withdrawal is extremely uncomfortable, but is not something that is fatal. I think people have described feeling like they wish they would die because they're suffering so much, but it actually in and of itself is not. However, as we know, certainly now that with the epidemic of opioid overdoses, obviously things like heroin, fentanyl, prescription pain pills in overdose, those can be fatal. And so the intoxication state is something that can cause death. So with alcohol, what happens when you withdraw from any substance, you get the exact opposite of the effect. So with alcohol, it's generally a depressant. It definitely slows things down in a person's physiology. But when you are withdrawing from it, and this starts to happen 4 to 6 hours after a last drink, you get the opposite effect. So you get agitation, your heart rate goes up, your blood pressure goes up. You might have tremor, sweating, and nausea, and actually being put at a risk of seizures. So you basically get this, what I would call a fight or flight response, an adrenergic or epinephrine adrenaline response in the withdrawal state. Let me contrast that just briefly with stimulants. Cocaine or methamphetamine intoxication clearly causes people to be overstimulated, not being able to sleep. Their blood pressure goes up, their heart rate goes up. When people stop using stimulants, essentially you go into what's called a crash. And you get sleepiness, you get hungry, your mood actually goes in the opposite direction of euphoria, that people get depressed when they're coming off stimulants. Now, when people become addicted to alcohol, physiologically dependent, they will have alcohol withdrawal as a feature of their condition. For example, sleep is often very jangled from alcohol. I think those of us who've had one too many on a Saturday night at a party will realize perhaps that you're not sleeping very well that night. And essentially what happens is you're starting to withdraw from alcohol about 4 or 5 hours after the last drink. So if you go to bed at midnight, you might start waking up at 4 a.m. And one of the reasons you're waking up is that you're already in an withdrawal. So your brain is telling you basically it's time to wake up, it's time to be stimulated, when in fact, you're not, it interrupts with the normal sleep pattern. So what happens is when people have a more serious addiction to alcohol, they often will have withdrawal symptoms in the morning. Now, a bad hangover is alcohol withdrawal. But when it gets to a range where people are shaking, throwing up, to the point that they need to drink to actually treat the withdrawal symptoms, that's kind of you getting into a whole nother category. And a number of people that I've seen will drink first thing in the morning, an eye opener, hair of the dog, to deal with withdrawal symptoms. So alcohol withdrawal symptoms, if gone untreated, particularly in people who are drinking 8, 10, 12 drinks or more a day, and there's a subset of people that we see, then you get into a risk of alcohol withdrawal going beyond shaking and throwing up to actually perhaps having withdrawal seizures or developing more severe symptoms of alcohol withdrawal, which can include hallucinations and disorientation, and a condition called delirium tremens. Delirium tremens, a lot of people will use that term very loosely and say, well, he had the DTs. Well, most people don't have the DTs. They have this more, what I call garden variety, alcohol withdrawal, shaking, sweating, nausea, very uncomfortable. But actually delirium tremens can cause death. And often people will end up in the intensive care unit. So The rationale in treating alcohol withdrawal in part is to prevent a progression to those more serious conditions. But in a long-term alcohol treatment program, the other reason to treat alcohol withdrawal symptoms is that it will delay the onset of drinking. So in other words, giving a medication, we prescribe a lot of gabapentin. Giving a medication will delay the onset of drinking that day. So if someone is taking a drink, at 9 a.m. because they wake up shaking and throwing up, they can take a medication and then at a minimum, at least delay the onset of their drinking for that day. So there are multiple reasons to treat alcohol withdrawal. And then as you may know is that alcohol can also be fatal with alcohol poisoning. So if you have a very rapid raise in your blood alcohol concentration over a period of a few hours, that can be fatal. Essentially, your brain swells and you have seizures and you can die. And that happens with people. Unfortunately, it can happen with, again, adolescents and young adults, probably at a greater rate than the general population. But those situations where someone will drink a whole bottle of spirits, 750 milliliter bottle, vodka, whiskey, and get that blood alcohol level basically going from 0, to 0.4, 0.5, that can be fatal. So.
Right. So to me, it makes sense that there's a different way to maybe approach treating alcohol use disorder than the traditional cold turkey, right? That we have this other method, a more focused approach. That's, I guess we would call it a harm reduction. Is that?
Yeah. Yeah. I mean, so here's the way that I think about it. And I think what happens with these the terminology of abstinence versus harm reduction is that there's a subset of people that get very hardened in response to the other. And in fact, it's a very unproductive, not a useful dichotomy, in that having a goal of stopping completely is the right goal for a lot of people. And you can come to treatment with a goal of stopping completely, but the way to get there might occur over a period of weeks to months. And the reason that then technically is, quote, harm reduction, the reason that works so well, it's really two different reasons. And I have this conversation with patients every week. One is, if you go from 8 or 10 drinks a day to 0, you're likely going to have a seizure and end up in the hospital. And we can prevent that from happening. I mean, you can prevent that from happening by slowly weaning yourself off. I have a lot of people who come to the program who've already gone slowly reduce the amount that they're drinking. And the good news is sometimes people come having 4 or 5 drinks a day, whereas a month earlier they've been drinking 10. But when you come to a program like Ria Health, we can help continue that reduction process in a medically safe way. Second, in my opinion and in my experience, that often works better than going straight to abstinence. Over a period of months, the outcomes are pretty much the same. That yes, you can go straight to abstinence as long as you do it safely, or you can reduce over a period of time and get to 0. The reason I think that this works is that having that time, weeks to months, of not only taking care of the medical aspect of the process, which often includes medication, which we can talk more about, but also start the work of changing your behavior. And the discussion I have with every new patient that comes in going, medications are a tool. Medications are going to help you cut down. And as you're cutting down, you'll have more confidence that you can do it. And they're very useful. But don't expect that the medications can be a magic pill and do all the work for you. The really harder work and the more useful work in the long run is changing your behavior and changing your relationship with alcohol.
Right, because some people that know a bit more about the program and say the Sinclair method might say, well, why don't I just get the medication and try this on my own? And so what would you say to that?
So a lot of people come in reading about the Sinclair method. And the Sinclair method, for those of you watching this, is essentially what we would call targeted dosing using naltrexone, and using it only on the occasions that you plan to drink. And in fact, the Sinclair method works well for those who are drinking 1 or 2 days a week. and often on a weekend, and often drinking much more than you plan to drink on that occasion. And the thought there is that the naltrexone taken really an hour or two before you start drinking will actually physiologically make it easier for you to drink less. The way that naltrexone works is pretty interesting. It actually reduces the reinforcing aspects of drinking. It makes it less pleasurable. This is not the same as antabuse. And a lot of people come into the program and they've heard of a medication called antabuse. The chemical name is disulfiram. And antabuse is the old school medication where if you take it regularly and you drink on it, you get extremely ill and maybe need to go to the ER. It's more of a punitive approach. And not that our use of disulfiram is completely gone. It's just that it's not at all a first choice for us. So naltrexone won't make you feel sick. When you drink on naltrexone, you're not going to get deathly ill. But what you might notice is that, I don't know, I didn't get as much out of that drink. And so it was easier for me not to pick up the next one or to keep going. So people come back and they go, instead of drinking to blackout, and frankly, a lot of people who are looking into the Sinclair method, they're drinking to a blackout state on Friday night. And often, basically a blackout is an amnestic period of time where you're functioning, you're operating as, in a way, a robot or a zombie, but you have no awareness of your behavior in the moment. And clearly that can be very dangerous, and particularly when you're out in public settings, what you might say, what you might do, what others might do to you. So people do end up hospital, jail, in a blackout state. So if you're able to stop at, let's say 5 or 6 drinks, which frankly is still plenty, or 7 or 8 even, but you're not going to 15, well, that's a great step in the right direction. So the Sinclair method works really well for people who drink in that episodic binge pattern. Mm-hmm. Naltrexone actually, for those people who drink, I would say any more than 4 or more days a week, that naltrexone on a daily basis is a better choice for an overall treatment program.
So the benefits for someone who can significantly reduce or stop drinking alcohol, talk about some of the things that people experience once they start to see some success in a program like Ria's.
So a number of people who come to our program have already had serious medical or physical consequences from alcohol. In short, alcohol impacts multiple different systems, but I would say these are the 4 major systems it impacts. Clearly, it impacts the liver. Excessive alcohol use is toxic to your liver cells directly. It affects your heart. And a lot of the patients that we see have hypertension, and some people will have high blood pressure without being a drinker, but being a drinker increases your risk of hypertension. And furthermore, it increases the risk of affecting the cardiac muscle, and in many cases, contributing to atrial fibrillation. And the reason atrial fibrillation, which is an electrical conduct problem of the upper part of your heart, is that it puts people at risk for blood clot formation. And when you form a clot in your heart, you're at risk for that blood clot to go up into your brain, causing a stroke. So there are definitely cardiac consequences from excessive alcohol use. The third, so we've got the liver, we've got the heart and your cardiovascular system. The third is your bone marrow. And in fact, folks who have a long history of excessive drinking at some point may develop anemia, low white blood cell count, and low platelets. Platelets obviously important in your blood clotting system. And in fact, one of the reasons it can cause anemia is it will interfere with your body's ability to absorb vitamin B12 and folate. So a number of people will have abnormal red blood cell indices early in the process as an early indicator of excessive alcohol use. Liver, heart, bone marrow, and the fourth is your brain. So there's a high association between excessive alcohol use and depression and anxiety. With depression, it makes sense, right? People drink for a reason. And I think a lot of people who have depression will drink to self-medicate depression. And of course, most of those people will realize pretty quickly that the alcohol may soothe you in the moment, but in the long run, it's going to make your mood worse because alcohol is a depressant. With anxiety, it also seems natural that people would drink to reduce anxiety. It's very common. And this could be panic attacks, social anxiety, or just obsessive compulsive thinking or any kind of anxiety. It works great in the short run. In the long run, you can get into a pattern of essentially having alcohol withdrawal cause anxiety. And then not only are you treating your shakes and your sweats and your nausea, you're also treating your anxiety. And the anxiety is a rebound from stopping drinking. And then in the long run, excessive alcohol use can lead to dementia. So it can affect your brain, both from a mood perspective, anxiety perspective, and also a cognitive perspective. So it's a long-winded way of saying is often people will come in with elevated liver function test, 4 or 5 times the upper limit of normal. And they're on their way, if this continues, they're on their way to structural change. They are on their way to structural changes in the liver, including fibrosis and eventually cirrhosis. And so by stopping or reducing your drinking at that stage, the liver function test will normalize. And that if you can catch it before you have structural changes in your liver will regenerate. It's amazing. It's an amazing organ in its ability to regenerate itself. So
that's encouraging to know that,
yeah,
even after years of drinking, you can have those kind of outcomes if you do something and take care of it sooner than later. And so you've talked about some of the serious physical issues that come with alcohol use disorder. But as a practitioner, I'm interested in your experience in the recovery process. What have you seen in terms of some positive outcomes, people's relationships and sort of their work functioning? What does that look like?
I know us doctors were terrible because we're always emphasizing the pathological. And I think part of it is, emphasizing the positive aspects. So people who arrive at a place like Ria Health often do it in response to negative consequences in their day-to-day life. We live in a family, we live in relationships, we live in a community, and we have a balance of both work and home life. And so the motivation often to change your drinking behavior comes from pressure at work. For example, you may be aware you're not as sharp as usual, or you may miss work from a hangover, and that you may even be getting in trouble or your performance reviews are slipping. And so when you're able to get a handle on your drinking and drink less, it's remarkable that you are sharper. You're less likely to miss work from a hangover. If we look in the home front, a lot of people get to us because of, frankly, pressure from loved ones to reduce or stop. And so that motivation, it can be very important in helping people reduce. What people find, and I see this all the time clinically, is when they've been able to reduce, and on average, the people in our program, the patients in our program, reduce their alcohol use by 50% in the first 30 days. When people are able to significantly reduce, one, they feel better about themselves. I thought this was an insoluble problem, that I was just going to have to surrender to this. And they find that they have some agency, and they see that they're able to get some progress with their drinking. They're also finding support then from home. That I just talked to a woman yesterday who has been able to be completely sober over a period of time. And her 10-year-old said, "Mom, you're never going to go back to that, are you?" I mean, essentially, that her whole household is really happy because she's had a change in her behavior. So to me, working with people with alcohol use disorder and other substance use disorders, when you first start in training, you find this population to be very frustrating. And when you're in a hospital setting, what do you see? You see the people who are unable to stop. And so doctors can be nurse practitioners can be very cynical about alcohol users, because you see the people who aren't getting better. When you have more experience and you see people in outpatient programs getting better, then I feel much more optimistic about this group, because I know it's treatable. And I know when people are able to turn the corner, their life transforms. And honestly, it's a 180. You can see a 180 in substance use disorders, where in other chronic conditions, both medical and psychiatric, often the progress is much slower. But in a substance use disorder, if someone is able to get to a point, frankly, of stopping completely, they completely transform their lives. work, relationships, parenting, physical health. And then what happens is then people do get more serious often about self-care, because self-care goes by the wayside when people are focused and spending time drinking. They stop exercising. They stop watching what they eat. They're ingesting empty calories. And the more weight they gain and the worse their sleep is and the less they exercise, it's sort of like what I sort of say is sort of a downward spiral. You get the exact opposite in recovery. So when you start to come out, all the positive things start building on themselves. So I see people transform their lives and they return to being the person that they used to be. Right. And that people come in and say, I want to be that person I was before I started drinking way too much. Right. And the reality is a lot of people we work with find their way back. And I mean, that's really the gravy of doing this work, is when you have people you've followed for a number of months and they get to a point and they will look you in the eye and go, I didn't think I could do this. And I have my life back. And, you know, that person did it for themselves and they did it for their family. They did it for their partner. They did it for their children. And so, I mean, I've seen amazing things when people can get a handle on these issues. Mm-hmm. It's a 180. They have transformed their lives. And that's tremendously satisfying.
I can imagine. And you touched on something that I just wanted to bring up, that they come back to themselves, and this idea of kind of personalized care seems to be a factor in people recovering successfully, as opposed to sort of like a one-size-fits-all program. Mm-hmm. So in your experience, because you've been doing this for a number of years, how important would you say that is to kind of meet people where they're at and just, you know, just customize a plan for people based on who they are and what their needs are at that time?
Right. That's one of the most satisfying things about the work that we do, is getting to know a person, and then actually, after talking to them, putting together sort of the medical variables and the diagnostic variables, but really beyond that, then coming to a plan that is suitable for them. And that's really satisfying when you're interviewing someone and it starts to coalesce in your mind, kind of what combination of both medication and other coaching interventions are going to work for this individual. And it's nice to have that conversation at the end of the first visit and go, here's the plan, and really believe it when I say it. It's like, I see no reason why you're not going to do well in this program, and give people a sense of purpose and confidence in the program. So what I really like about Ria Health is that we are face-to-face. Granted, it's remote, but when I have patients, they have a relationship with a doctor, nurse practitioner. They establish a relationship with their coaches. And to me, I think the fact that we use medication plus coaching by certified addiction counselors with quantitative outcome measures, meaning breathalyzer readings that show blood alcohol concentrations, it's the combination that works well. But I do think it's the personal touch that we are face-to-face and we are in there with the patients. They know who their supports are within Ria Health.
Right. And while, you know, this study coming out had some alarming statistics, it is very encouraging and hopeful to know that programs like this exist. And I really want to thank you for taking the time today to discuss this important topic.